Good afternoon and welcome to the Hamilton Health Sciences Department of Medicine Grand Rounds. Uh, Today, I'm very pleased to introduce my colleague, Dr. Haroon Yousuf, who's going to talk to us about this massive quality improvement project and what we believe is the largest transformation in the Department of Medicine in the recent past, and absolutely the largest in Hamilton Health Sciences following EPIC. He's going to talk about the transforming medicine at the Jaravinsky Hospital that has affected literally every one of us, mostly in a positive way. Haroon is a general internist and the assistant professor in the Division of General Internal Medicine, who completed his medical training at McMaster University and has a master in bioethics from UFT. He has an interest in clinical ethics and the hospital medicine innovation. He is the academic hospitalist lead for McMaster University Department of Medicine. He's the Hospitalist Fellowship Director and the head of service for acute medicine hospitalist at the Jaravinsky Hospital. As I read his titles, I thought there may be some more. Actually, he hid away from us because he holds multiple titles of leadership around the hospitalist service and otherwise. And Haroon has become like I don't want to say a household name, but actually at least, every meeting name, across the hospital and university, as he led this large transformation that's impacted all of us, as I said, in a very positive way, and the successes that actually resonated across the country in rolling out the hospitalist service and helping the residency program and the department and the hospital through the last 18 months, working hard every day. And he's going to tell us all his secrets today. So please listen attentively. Haroon, the floor is yours.
Great, thanks.
The floor is yours.
Yeah, thanks for that kind introduction, Dr. Zam. You're too kind. I'll jump right in. I'm going to be presenting on some of the lessons that I've learned from this hospitalist transformation. It was definitely, Dr. Zam mentioned the work I've done, but it was definitely a team effort. And a lot of the lessons that I'll be presenting today, they're things that I put into practice, but a lot of them are things I also observed other senior faculty members and healthcare administrators doing. So we'll go over that. Before I begin, I want to express our land acknowledgement that McMaster University and the Hamilton Health Sciences recognizes and acknowledges that it is located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the DISH with the One Spoon Wampum agreement. I'll get right into a story. So, there are lots of negotiations before this, but for me, this started on a warm spring April in 2022. I was gazing out at the Hamilton skyline, the beautiful Hamilton skyline, and Khalid, he interrupted my reverie and came up to me and asked me if I want to consider applying for this academic hospice lead position created at McMaster to help guide this hospice transformation. And, initially I was definitely intrigued, I was interested, and I recognized how important this role would be and how it would help me from a learning perspective and with career growth. But, whenever you're tackling something new, you're also, especially a project where there isn't a set blueprint, like in this case, there isn't a blueprint for any university hospital, a tertiary care hospital going from a clinical teaching unit model to a hospitalist model. So there's really no blueprint for that. So whenever you're tackling something that is definitely a lot of nervousness, anxiety, fears, how are you going to navigate that uncertainty is really key. And because there wasn't this blueprint, I think for me, the single most important thing I thought about when I was evaluating the pros and cons of taking on this was, what would it look like if I didn't succeed or if we failed at implementing this. And, I was fortunate enough that I felt that the senior leadership, both in the university and the hospital, quite supportive. And then even if we weren't as successful as we hoped to be, we'd find a way through it. And so that's really key. But I think the other big important thing is I'll talk about our team that we coalesced to build this. But it's really important to also have a team that supports you. So there's a team that's working on the project, but there's also a team that helps you navigate your own personal challenges and your uncertainty as you tackle such a novel project. I think that's key. And for me, that was finding good mentors, good coaches, to help me guide through that project and help me regulate myself as we go through this project. So I mentioned the team. I'd be remiss if I didn't put this up front. This is, you can see here, this was a very large scale effort with many individuals involved. We had many individuals from our faculty, from Mohammed Panju and Sharik Haider, who co-chaired our Hospitalist, our Juravinski Transformation Working Group. We had Leslie Martins, our colleague from the IM and GIM programs, contributing as well. We had extensive engagement with hospital operations, hospital leadership. Liz Ferris, the director of medicine at Juravinski, and her team, and Tanya Roglic from Medical Affairs really collaborated closely with us. And of course, we had our executive sponsors, Mark Crowther, Annette Rosadi, Khalid Azam, and Neil Johnson, who helped guide us through the way. And so I don't have any clear objectives for this talk, and I'll put up a poll if you could consider filling that out. I think what's important as I go through this is I'll be talking about the different lessons we had, and I'd like you to think about what are your active learning objectives. What's an objective for you in terms of trying to determine what you get out of this? Because I'll be providing a high-level overview of the different things that we did and the lessons, and then I'm hoping you can look towards what is relevant to you, and then you can read around that more, build that up. Typical, academic answers, read around the topic, right? So I'll move on to the timeline so you get a sense of how quickly all this had to happen. So while I was approached in April, I think we really got our boots on the ground and got working on this in September, right? And so this was in September 2022 when we had the mandate from the HULC, who had done a lot of negotiations before already, and that's the Hospital University Liaison Committee, which it consists of senior leaders from Hamilton Health Sciences, St. Joe's, and McMaster University. So I think they had done a lot of the background work. We got our mandate. We created we worked on within the working group that was created by Mark. So you can see the timeline. By January, we had met as a group, negotiated how we wanted to make this work, designed it, and we had finalized the model of academic teams and hospitalist models. So the care is at the Juravinski is really split between, I'd say, about 25 to 30% of the care for medicine patients is looked after by these academic teams, which are staff and a resident and a PA, a preceptor type model. And the rest are all looked after by the hospitalist team. I'd say they look after, between our acute medicine hospitalists, between 200, they probably look after 180 patients, and the multi-specialty hospitalists look after another 100. So the large majority of the patients are being looked after at the Juravinski by them. So by Jan, we created that model. We then went about publicizing it and projecting our vision to the rest of the department. By March, we had our physician recruitment complete. We had our daytime schedule complete. And you can see we were working right up until the last minute. June, we had our EPIC build complete, handover processes, referral criteria, patient flows, all of those things complete. And by July, the onboarding credentials was happening, I think, even up till mid-July. We were working on paging, communication algorithms, all those things right up until the last minute. In terms of credentials, just a word of advice, I wasn't able to implement this because I hired so many new physicians. But if you're hiring new grads, make sure to schedule them after the first few weeks of July, because credentials does take some time to sort out their license, and so does CPSO upfront, so that delays their start sometimes. You can see above the critical thing that I think to help with the success of this model is how we were engaged in communication and collaboration with stakeholders throughout the entire time, right? We were constantly trying to communicate, ideating, prototyping throughout, and listening to feedback. And I think that has really helped both in the design, the rollout, but also in terms of allaying any of the anxieties and the fears that people had with having this transition happen. So a lot of what I'll be discussing today is centered around change management. While we didn't intentionally use the Cotter's 8-step model, when I reflect back and I look through the model, it does reflect a lot of what we did. And so this is probably the most, Cotter's is the most prevalent model for change management. Luckily, we didn't have to establish a sense of urgency. It was already there. The residents were leaving the Juravinski on July 1st, so we had to get things done. We created a guiding coalition. We developed a change vision. We communicated that. We removed barriers. We generated some short-term wins. And I'd say right now we're in that step 7 part where we're trying to build on that change. And hopefully we get to a point where we can anchor some of these changes into the way the hospital and the university function. So when I break down the 3 stages of our hospice transformation, we had first the design, second stage was scaling and scaling up, and then the third, which we're hoping to build on right now, is innovation. Within design within the design process of our hospice model, I think there were 5 key principles that help things work well. The first was having a vision, establishing priorities, negotiation, and doing that effectively, and then getting to stakeholder engagement, and finally using some design thinking to create the way as to how these hospitalists would be working in a tertiary, sometimes quaternary care academic center. When I developed the vision for our hospitalist department, I think whenever you're developing a vision, it's important to keep things simple, plain language, something anyone can understand. And that's our vision for this project that we have is to make sure that it's the premier hospitalist program in Canada. And our core values are to make sure that we engage in excellence in clinical care, that we are a highly desirable physician workplace, that we pursue excellence in hospitalist education and become a leader in hospitalist education, hopefully throughout Canada. And finally, that we're leading within our region in terms of quality improvement and innovation. And those are the big vision, the values. And I think it's really important to develop a vision up front, because especially as you're going through negotiations with different stakeholders, it gives you some common areas to agree on and to coalesce around. The next thing I'll talk about is priorities, and it's key whenever you're taking on a large project that you develop priorities up front. And the 2 main things on reflection that I found were important in terms of how priorities helped us is, 1, it kept us on target. I put here beware of scope creep, and that's basically as you take on a large project, there's a tendency to have more and more things added to that project. And particularly when you're taking a large project in healthcare and hospital, where there are lots of challenges and lots of problems to solve, you may have many different departments and individuals reaching out in terms of asking you to help solve all of their problems. And so it's important that upfront you have these priorities so you're able to stay on target. And if those departments' issues align with yours, there's synergy, you can work on them. If there isn't, you really have to try to make sure you're staying on target. And the second thing is the priorities really help with ideating. It gives you some constraints. It tells you that it informs everyone in the group what's important and helps with that effective ideation. Priority setting in academic medicine. I mean, this could be a grand rounds on its own. There's a lot in the health economics literature and the ethics literature on how to set priorities effectively in medicine and in academic medicine. I think the key things that need to happen whenever you're setting priorities is to make sure that there are some explicit criteria that help you determine how priorities are set, that those criteria are transparent, that they're relevant to all stakeholders, and then that there is QI of the process. So the process of setting priorities constantly revisited. And I think the best model that encapsulates this is the accountability for reasonableness model, which basically uses 4 Rs to describe what I've said just here in terms of how to make things relevant, how to make them transparent. So if you have any interest, that's a great way of how to communicate your priorities in terms of making decisions on funding and how to make those decisions. There are multiple decision analysis tools. There's, for instance, a value-based judgment. There's the multi-criteria decision analysis, and there's also the program budgeting and marginal analysis. And those can all help in terms of determining how you can make funding decisions, based on evidence, based on the impact to community, based on the importance to your academic mission. These can help guide how those priorities are made. So, once you have your priorities, it's really important to try to think of how you're going to tackle them, right? So you definitely, whatever is really important and urgent, you want to do those priorities, tackle them first. They're not as important, but they're urgent. Try to delegate them to other members who may be less senior in your group. Things that are really important and low urgency, you can schedule to do that later. And things that aren't that are important or urgent, you should generally avoid. And that's the same if you want a simpler matrix to help determine your priorities, you can also use the impact effort matrix. I presented those more complex tools first, but these are other ways that you can help to determine your action priority matrix, right? Things that are high effort, high impact, those are your major projects. You want to invest time into those. Things that are low impact, lots of efforts, thankless tasks, you typically avoid them unless there's some burning reason why. And then things that are high impact, low effort, those are your quick wins. You want to, especially if you're having difficulty with momentum, focus on those. And low impact, low effort, you can decide on when to do those later. So we talked about priorities. And so once you've developed your priorities, we moved into negotiations, both between faculty, but also at the hospital level. And I think it's really important, Mohammed Panju mentioned this to me, that if you begin your negotiations, especially if the high stakes negotiation in the meeting, they're already destined to fail, right? So it's really important whenever you're doing negotiations that you think about the pre-meeting, right? And so in addition to vision and priorities, you want to make sure that you have mutually agreed criteria, ground rules, and terms of reference. That really helps for everyone to understand how they're approaching these negotiations. It's also important that you identify all relevant stakeholders and who they represent. It's key to recognize that you're not seeking conflict in negotiation, but to normalize it. Conflict is going to happen, especially if it's high stakes negotiation. It's going to happen. You just have to normalize it and come up with plans on how you're going to manage it. Another key thing that helped, myself whenever I was going into our discussions and our meetings was to complete an accusation audit. And that's basically where you compile a list of all the negative things that the other side might think, right? And that helps you to appear as fair as possible, as transparent as possible. And empathy is really key for that. It's also really important to meet with individual stakeholders before group meetings to get a sense of what's important to them and see how you can incorporate some of their concerns into the way that you manage the meeting. It's also really important to make sure if you're having negotiations, to make sure that there's an agenda, there's some schedule, there's a framework for negotiations, and then that will further inform design. And then finally, the last thing you want to be thinking about is setting, right? Where are these meetings and negotiations going to happen? Are they going to be in person? Are they going to be virtual? Are they going to be hybrid? And what are the risks and benefits of both? And a lot of what I'm discussing here is adapted from Chris Voss's book on Never Split the Difference, a great book on negotiation if you're ever interested. Negotiation during the meeting, it's really important upfront to be inclusive, so make sure everyone has a say. You don't want that some individual feels silenced, and then after the negotiations, then they feel like they've not gotten a fair deal. So it's really important to make sure that you're inclusive. It's also great to become comfortable with silence. Silence is really important in negotiation because oftentimes, if you're silent, you can't come up with an idea. Someone else may try to fill that void with some type of concession or another idea. So it's really important to become comfortable with silence. Mirroring is another effective way to help build trust whenever you're negotiating and meeting with people. So for instance, when someone says a point, you can repeat that point, ask them to clarify and see if you truly understand that point or you're paraphrasing it correctly. And that really helps to build trust with everyone in the room. It's really important to use calibrated what and how questions. So, that really helps the other party explain themselves well. You want to make sure you're being as fair as possible. And that's why creating that accusation audit to anticipate concerns surrounding fairness really helps you when you're in your meeting. And finally, you want to think about loss aversion. So understand what the others fear losing the most. So once we got into negotiation, through that, within our group, we then got into a lot of stakeholder engagement. And I think this is really key because stakeholder engagement helps helps identify what's important to your stakeholder, but also helps you identify any blind spots in your design. There are things your stakeholders will bring up that you may have not thought of. So it's really important. It helps them create that co-design. And then many of these stakeholders who may be external to your design team may actually become change champions and help support you as well. So it's really key upfront to do that stakeholder engagement. I think it's a big part of why this is able to work well. And you can see here all the different individuals from faculty, administration, residency programs, hospital operations, medicine subspecialty. I think we met with pretty much all the subspecialties that have MRP status or are heavily involved with inpatient work. And of course, with us, major stakeholders, ER. So meeting with them regularly to see how we could co-create this model. So when you talk about the design elements, when I got around to creating the actual design of how things work, I tried to use as much as possible a lot of elements from design thinking. So to have that empathy, putting ourselves in the space of what a day looks like for a hospitalist, defining what are those important questions we have to get right up front, and ideating, prototyping, and testing. So we really got a sense of what the constraints of all our stakeholders were. I think the other thing that was really key is when we were designing it, keeping in mind that the fee schedule was really important. Knowing that fee schedule is really important, and if you are designing a clinical service, I advise you either learn the OHIP fee schedule really well or you work with someone who does. And then as we got into the design, we use a lot of Google Forms, Zoom polls, focus groups to help us collect data and help the physicians feel like they're a part of the design process. And as we were trying to recruit physicians, I think for a physician, it's very you'll always feel uncertainty when you're working in a program that is completely new and nobody has had any experience working in it. So I think this really helped the physicians who are going to work at the Juravinski feel like they would be well supported. From a hospital standpoint, we collaborated very closely with hospital operations. And I think this is something, if you're ever considering working and designing a clinical service, it's really important to engage with some of these partners that we worked with at the hospital level because they've been critical to our success, right? So we not only engage with the medicine department within the Juravinski Hospital, we engage with quality, we engage with medical affairs, credentials, EPIC, the EPIC Odyssey team, decision support, who helped gather so much data for us to help us determine how many physicians we clinical managers, interprofessional practice, and finally organizational development, who helped really get feedback from nurses, allied health, and then helped us message things appropriately to them to help them feel comfortable with this change. We had a great project manager who helped keep us on task, and that's really key whenever you're doing this, is to major projects, is you need to have a project manager addresses milestones. We created a lot of visuals, flow diagrams, and that really helped us. And then we, as you mentioned before, we use multiple forms of engagement from the hospital as well. With all the hospital employees, we use surveys, we use email memos, we use SharePoint, we use presentations and focus groups. And it's important to have this multi-pronged approach because every staff or physician engages with the organization in a different way. And so when you use a multi-pronged approach, you're able to capture as many physicians and staff and inform them of the change. So that was the design. We'll shift gears to this phase of scaling. And so whenever you're scaling, I think that the first step is always recruitment, right? So how do you find physicians? I think it's important when you're, and this is probably the most common question I get about the hospitalist transformation is how I found physicians. And so it's really important to have a sense of what type of physicians that you're looking for, the exact type. You want to be thinking about your team. So upfront, model how many physicians you need. When we modeled it, I felt that we needed about 30, 32 full-time, part-time. And then we need probably around a good 30 locums. And then we added 10% to that because, when you model, you're thinking about an ideal world, but people get sick, people have parental leaves, all kinds of things happen in life. And so it's important to build that in upfront. And then you also want to be thinking about what physician phenotypes do you need, how they complement the team, right? There's a certain phenotype of physician you need to manage the nights, to manage the day, to manage the growth period, the uncertainty period, and then to manage the period where things get more stable. So you want to be thinking about that. When you do advertise, you want to make sure that you're doing it in a way that's relevant to the goals of the patient, the physician. So minimize filler words, skip those long intros, right? Physician doesn't want to read about how they need to meet CANMED's roles and those type of things. Be very specific about work and remuneration, and how that works, and use images to draw people in. So that was the advertisement. The next thing we recognize, because it's a busy hospital, and like I said, people may come, they might be hired, they may work for a couple of years, they may leave, things happen. It's important to build a pipeline of talent, right? So we talked about, so we did the advertisements, we used all of the traditional ways to recruit, which are Health Force Ontario, CMAG, CSIM, all of that, the specialty journals, academic departments. But the other avenues that really helped us is, we sit on a gold mine of recruitment, which is the internal medicine program. And so I approached Jan Taylor, who's always, great resource, and she provided me with the email list of all the residents who had recently graduated who are eligible to practice independently. I spammed them all, right? And that really helped generate a lot of interest in the program. Talked to a lot of PGY4 IMPDs. They're a great resource as well. And then you can also use social media. So LinkedIn is a great tool to help recruit physicians from the US. It's also great tools if you're interested in recruiting visa trainees and international medical graduates, because a lot of them actively use LinkedIn. For Twitter is great. We didn't use it, but it's great for hoping to recruit more academic-minded individuals who are more interested in med ed. And then finally, if you're looking for a family physician, then we do have a few family physician hospitalists. Facebook is a great, there are specific groups within Facebook that can really help with recruiting those physicians. And then finally, once you've done that, you want to create a sourcing system. So I think that really helped us up front was holding, we had a couple of info events where people could come and learn about our Juravinski Hospitalist model and what it would be like working there. And then we used those places to gather data on how we could design the project. So design the hospitalist model. So how could we split up shifts, all of these type of things. I used these info events to actually gather more data that would help us in prototyping our design. And then finally, once you build that up and you've had these info events, you've generated enough interest, you then create a referral network. And now we don't have to advertise, and we are regularly getting people who are interested in coming to work at the Juravinski. So, that's really key to build that up. The other thing that really helps with scaling is streamlining processes. So you want to automate as much as you can, right? So we've now moved towards our scheduling app, which is Pedal, to help automate things as much as possible, have people trade and switch shifts automatically without us being involved. I also, when we created the orientation, we use multiple orientation modalities. I created a lot of info sheets, PowerPoints, flow diagrams. And whenever people have orientation questions, I send them a lot of that because, and FAQ sheets, which have a lot of information, that helps to make it such that I'm not orienting a ton of physicians. Because in terms of the number of new physicians working at Juravinski, we had about the 75 hired. We also have about 30, 40 academic physicians who never worked at the Juravinski who now rotate through the academic teams. And so creating templated emails with all the information, with FAQs has really helped. All that has helped decrease the burden of having to orient every single individual individually. And PowerPoint's really helped. And then as the thing that I find now is helping quite a bit is using AI language models to help assist in creating policies in terms of reference. So you're not using this model to create everything, but it's definitely helping in creating those policies and those terms of references, and gives you that initial momentum to get those things going. The other thing, I looked at this hospitalist model as a bit of a startup, right? And so as you're scaling, as with anything that's new and like a startup, you need to be able to pivot. And so an example of that is while all this was happening, we were also building up our hospitalist fellowship program. I'm indebted to Azim Ganji for all of his help with that. We also have had our REC members contribute as well. And so as we developed this, initially our aim was to try to get US trained internists who are trying to meet their CPSO requirements. And of course, family medicine trainees and visa trainees. The visa trainees, things went well, but while we were developing our program, CPSO requirements changed. They dropped the requirement for extra training for US grads. And so we had no US applicants because they could practice independently. And so we also didn't have as much interest in family medicine grads, which has now changed. And so, to get that project off the fellowship off the ground, to get that minimal viable project in the way they think about in the startup world, it's not perfect, but it's able to get through the door. We pivoted to getting IM trained specialist IMGs. And there's a bit of an uncertain world. We worked with CPSO on how to make sure that can work through. And I was a bit worried about whether these individuals will be able to practice once they're done. Fortunately, one out of the two grad fellowship applicants, the current fellows we have now is well college eligible. The others looking into it, and so I do think there's a pathway for them to practice in Canada. And next year, our aim is to have both family medicine graduates, and when we do take IMGs, to make sure all of them are well college eligible. And so Samir asked the question, what led to increased interest from family medicine grads? I think with anything, it was a new program, and so there wasn't as much, there's questions of what it would look like. And I think now that the program is better socialized, there's been more interest from family medicine graduates. We use a lot of informal talking to me, speaking to some family medicine grads, and them speaking to others to try to get word of mouth out. And then through LinkedIn as well, we've created a lot of posts on our hospice fellowship, and that's definitely helped increase the interest in family medicine graduates. So in terms of our next step in that transformation is we talked about the design, the scale. The next step is innovation, and how are we doing that? So we've created now a post-discharge and admission avoidance clinic that's currently running in a completely virtual format. It's using our home virtual GIM program and supported by an NP, and we're hoping by February to have an in-person presence as well. So it'll be a combination of a hospitalist, an NP, and the virtual home GIM program working to support patients in their transition to the community. And the focus will be completely on post-discharge or admission avoidance. So people seen by internal medicine in Emerge and then referred to the program. So a bit different than our GymRac clinic, which takes direct ER referrals. These are discharges, and they typically have to be seen by an internist. And we're also developing Epic. We've also developed a lot of Epic dashboards that help feed a lot of data to myself. It also feeds it to Samir, and we're able to see how things are happening in real time to change. We've also embarked with our Epic team work on cognitive computing models. This is probably the area that excites me the most. And so we're working on the models to help predict readmission scores within Epic, and then hopefully that can guide our physicians when they're making decisions on discharge and how to arrange appropriate follow-ups. And the other area we're hoping to, so that project has just started, and the other area we're hoping to get into as well is a machine learning model to study ALC. As you know, the Juravinski Hospital, like most Ontario hospitals, has a large and vibrant ALC population. And so we're hoping to use these machine learning models to gather more data on ALCs, see where the pain points are, see if there are any areas we can make some changes. So I'll talk to why having Epic dashboards is important, right? So you can see here, the data we get fed that typically the Juravinski, even before the model, there's been since the model changed, there's a steady increase in terms of medicine admissions. I think some of that's overall volumes. Second is our increased capacity to take patients means we're able to, other services rely on us more to help out with admissions. Some of those have been conscious decisions, such as our collaboration with GI at the Juravinski Hospital. But you can see here the number of admissions have gone up significantly. And we saw particularly in November, December, due to a combination of the flu, RSV, and COVID. And there's also metapneumovirus going around, a huge number of admissions under medicine. And so these dashboards help us in real time to see how busy things are getting. And the scaling that we did in terms of the recruitment upfront and having that robust recruitment really helped us to be able to address this change. So by January 1st, we were able to roll out a sixth acute medicine hospitalist team that was able to manage, offload a good 25 patients from all the rest of the teams and help them come down to more manageable numbers. So it's really important that scaling and that innovation, scaling and innovation work hand in hand and really help to manage the service. We've also engaged through this change management process in a number of quality improvement. We've implemented some patient safety QI rounds, which are going well. We've implemented paging algorithms. I'll talk about paging algorithms in just a sec. We've also completed our scheduling and communication QI, which has helped to automate a lot more of our scheduling so that, the physician head of service and the administrators are spending less time on the management of the schedule. And I'm hoping the future is to create a QI lead and to engage with hospital more in QI. And I'll talk about some QI successes and some QI failures, right? Because in any project, there are going to be some things that go well, some things that don't really work out. So the things that I'm happiest about is the QI, the paging we did in QI. The QI we did in paging. When we were rolling out this model, I was quite worried about, particularly at night, with the high volumes of pages our nocturnists would potentially get. So before our rollout, on average at night, the different medicine teams would get close to 71 pages a night. And so if this is all going to one individual, it's going to be, very challenging. So we came up with some algorithms about when to page, nice visual flow diagrams for the nurses. We got our nurse educators and charge nurses to really communicate that out to them, and also overnight to be a resource to them about how to determine when to page. So that was really key. So there were certain things that they were advised could go through, could wait and not necessarily need to be paged about. Certain things maybe that could be messaged through Epic Secure Chat. And then we created a strategic rounding schedule. So we gave them all the different wards, different times at which the nocturnists would be coming by to check in on the patients. And so the hope was, when they're doing this rounding, concerns can be dealt with then in a cohorted way with the physician physically present, as opposed to them getting, working somewhere else and then getting interrupted constantly with pages. And, we socialized as well, and really indebted to our nurse managers, Brianna Elliott, and everyone else who was really big on making this QI work. And so when before go live the Hospitalist program, We averaged around 71 pages a night. We're now sitting at 60 pages, and I'm hoping to get that down lower. And we've also added, in terms of the number of patients we cover probably the medicine number of patients have increased by about 20. And we also now cover the hematology patients overnight. So we cover stem cell transplant patients and any patients under hemo, which is another 25 patients. These are very sick patients, some of them, especially the stem cell transplant patients, like it's almost like managing a step down. So the fact that we've added in 40 more patients, almost 2 medicine teams overnight, and we've decreased paging by the number of pages by 11 is a real success. And I'm hoping to keep driving this number down, because I don't believe that paging is an effective way to communicate. It's a good way to talk about. It's a great way to engage, to deal with emergencies, but really not a great way to communicate. And then in terms of the things that hasn't worked, cohorting hasn't been able to work. So our first PDSA cycle, when you initially started out in the summer, I'd say about 90% of patients were cohorted. Now, unfortunately, because of the surges, I'd say about 55 to 60% of patients are cohorted on the ward they're supposed to be. So this is definitely something that we haven't been able to work out yet. But that's the whole point of QI. You engage in multiple PDSA cycles. So we're hoping in our next PDSA cycles that we can broaden some of the stakeholder engagement, maybe engage ED managers and site admin to come up with some better flows as to how we manage cohorting. So that's our aim at this point. And so that brings me to the end of the presentation. I'll open it up to questions. I think we have about 50 minutes. I know everyone's busy. It's always good to have a couple extra minutes.
That's great I know there's a lot of conversation. Thank you very much, Haroon. This is took us through now almost 2 years of a journey, right?
Yeah.
Getting where we are. I think we have Dr. Holbrook. And so if you have any question, please type it in the Q&A. If you want to come in and speak up your question or discuss something, please raise your hand and you're in.
Right. Thank you very much. Can you hear me okay?
Yeah, perfect. Go ahead.
Excellent. Okay. Thanks very much, Haroon. That was excellent. And really the transformation, I think, is just absolutely remarkable. But I have concerns. As you know, there's always a but. And maybe, very well, the experience that I'm talking about, just finishing the 2 weeks over Christmas. So when I sort of recovered a bit and thought about it, my main concern, I think, is, do we still have a crisis in academic GIM? This has solved a problem. You folks have done, and yourself, a remarkable job, that this actually happened with the Hospitalist program at all, really is remarkable. But I'm not sure it's really solved our angst in academic general internal medicine. What are we doing up there with volumes that are teams of 36 or so with, in my case, one fellow admitting to our team, so having to admit and emerge at the same time, no junior learners, no sort of time for teaching, basically. And really, as you probably know, even in the other CTUs, using St. Joe's as an example, the team volumes are extremely high. And when I talk to folks from other universities, we still have the highest team ratios of patients. So it just makes me wonder. I think a hospitalist program is excellent. This is what's going to keep Canada going in internal medicine. But then that leaves the issue of, what is academic GIM really for? Is it just to teach, medical students and residents, or do we have another role? I think there's actually a bit of identity crisis there that we've, continued to uncover. I just wondered your thoughts.
That's a great question, Anne. Good question, and appreciate it all. I think and was worked just I was so impressed by all the work you did during December. Like, been a while since I worked with you. I think the last time was when I was a junior medical resident. So I was impressed that, skills are just as sharp. And so, I think that's a very valid question. And I don't know if I have the answer for that just here yet. I think that's something that our GIM executive and the future division director of medicine can help answer a bit better. And that's we have to get into some of that hard work, that questions as to what exactly is our academic division's mandate, and what is it that, when we contribute to work at the Juravinski, what is it that we're doing exactly there? So I definitely want to continue to engage in that work. I will. The good thing is, with that addition of that 6 team, we now don't have any teams that are more than 26 in terms of patient census, which I think has helped significantly. And I think that we'll be able to continue with those level of patient census. But that broader discussion is something I think the GIM exec recognizes is important, and we will have that discussion.
Haroon, if you allow me, I need to jump into this topic because I can't let this opportunity go, right? I think, and in my opinion, as a general internist myself and entrenched in hospital work as well as academic work for the last couple of decades, I say what Haroon presented today is the future of GIM. It is actually under the banner of hospital medicine as a hospitalist. But we are uniquely positioned in Hamilton, where we've created the service that's within internal medicine, within GIM, but under the banner of hospital medicine, working very closely with the hospital. I mean, it has been very impressive listening to this. It's not the first time I've lived this as well, but listening to Haroon putting this in 45 minutes and how entrenched this work in scientific backgrounds, quality improvement, design thinking, and close work with the hospital. It is the future of GIM. Like, we can't think that academic GIM is sitting in teaching rooms and exact tables, thinking about academia and forgetting where we practice most, which is the hospital. And the hospitals and the healthcare system is going to look at us, like, how are you going to solve the problem that we have no idea how to solve right now? And if we don't participate, I think, someone else will solve it in a way that we don't like. So it's just for our GIM academic leaders to think about as we embark on the future of GIM in this city and this country. That's my take on it. We'll take some questions.
Yeah, I think we have some good typed questions, right, Colin?
Yeah, so I think Amir, Dr. Chair Yousuf asked a really good question. Is have the ED physician, have you asked the ED physicians, floor nurses, allied health, how they view the transformation from our academic model to our current model, which is a mix of academic and hospital medicine? I would just add.
Yeah, so we did surveys, and I'd say in our surveys, I can't remember the exact numbers, I can share them with you later, but I'd say about 55% of them felt that improved communication between the physician team and the allied health team. And I think about 42% said that they felt that it had improved efficiency on the hospital floor. So I'd say it's definitely leaning towards positive in terms of communication from the ED physicians. I'd say on the whole, it's mainly positive. A lot of ED physicians really like the fact that they're speaking to a staff physician, and the referral process has definitely become a whole lot smoother for them in terms of making the referral, not having to speak to multiple stakeholders. And it's also helped them. And we do some ONC admissions till 8 p.m. That's really been shown. The ED physicians have really responded positively to that. The one concern is when things get really busy. So for instance, December 23rd, we got a record of 32 consults overnight. And things do get challenging then. But I think that would have gotten challenging even with our CTU. If we got 32 consults from 5 p.m. to 8 a.m., we would have been in a bind either way. So that's the one area we can improve on is how quickly we're able to see consults during those really peak busy times.
Thank you, Haroon. Ryan is asking a question about if you can tell us more about the newest innovation at the Juravinski, which is the admission avoidance clinic, post-discharge clinic that you're planning what type of patients you are going to accept, who are the referring people, and whatever more details, is it only for the Juravinski?
Yeah.
And I add to that, how are you going to scale it up to other sites in the future? Because that's really the big question now, how we scale up.
Yeah. Yeah. So, so far we've limited only to patients that are discharged from the Juravinski Hospital Service or acute medicine hospitalist and our multi-specialty hospitalist program. So far we're limiting it only to those patients because that's what we have the capacity for. It's for patients that have been admitted under those services or that have been seen by one of our internists in the ER. They have made a decision to discharge and are referring now to this clinic. So that's who can refer. One of either our hospitalists or the PAs who work with our hospitalist program, or the internist. So all of them can do that. And we are typically, our mandate is to see these patients within 48 to 72 hours. And currently, in terms of max volume, we are actively following in the clinic right now. I'd say about 20 patients. The initial aim was try to see everyone being discharged from Juravinski. I don't know if that's completely feasible, like every patient discharged by the hospital service, but we're working towards that. And yeah, I think I answered your question. Right now, it's only available for JH patients.
Thank you. It's a question from Jeremy Adams about, first of all, congratulations. He says, congratulations and huge achievement. And what do you think of the involvement of subspecialists and how do they fit into this system and how they can facilitate more efficient care and doing MRP work? And Jeremy is like one of the stars helping in the work there, in cardiology.
Yeah, it's been great, and his input is much appreciated. And so, I see the future at the Juravinski being much more of the shared care model, where the internists and the hospitalists and all the people who are part of the hospitalist service are increasingly the MRP, and then the subspecialists are coming in to help with consults, with management of those challenging patients, and then helping with that warm handoff into the community setting. Because as we go towards this, while we have this post-discharge clinic, the physicians we have, the phenotype is that they like to do inpatient work, and they have very limited outpatient scope and work. And so I think that's really where us offloading that MRP burden off subspecialists, I think, is what will help the subspecialists, and the subspecialists helping with some of the complex medical management and helping to ensure that warm handoff and support patients so that they ideally don't return to the hospital. I think that's the main aim.
There's a comment from another comment from Dr. Holbrook and a question. So the comment about the suboptimal allied health presence, we know, and it has improved a little bit, but not perfect yet. So I don't know if you want to comment on that, but also how we can improve the multi-D rounds in the presence of no cohorting. And I want to add to that, Haroon, it's like in your thinking, it's like with this all QI and innovation you're doing, and I know you're believe how important this effective multi-D rounds, is there a plan for a project on improving multi-D beyond what we're attempting on day-to-day to improve it?
I think, I do believe allied health staffing has improved. It's still maybe not where we'd like it to be. And the multi-D rounds have also improved significantly, but there's still a lot of work to go. I'm hoping once we get through this surge and we have our post-discharge clinic up and running, then my hope is then that we can get more, really delve into how to make multi-D work. And hopefully we can work on that simultaneously, concomitantly with our improving our cohorting.
Great, thank you. Question about the fellowship. So typically, how many you accept in your fellowship program?
Tell
us more about that. You didn't spend a lot of time on your fellowship, which I know it could be a grand round by itself as well.
So I mean, the hospitalist fellow, like this is why I wanted to focus on the clinical aspect of this. The hospitalist fellowship is up and running. And I'm thankfully I'm well supported as well by Azim in that realm. Azim Ganji, and Tammy Packer also plays a great role. She comes, interviews fellows, which is great. So McMaster sponsors training for 2 hospitalist fellows, and those can be IMGs, family medicine trainees. The US trainee pool is really dried up. And of course, we have some IMGs. So those are 2 sponsored. And then we have right now 3 visa trainees who are from the Gulf states. And my hope is, as that pool expands, hopefully we can take on more applicants. And I'm trying to see if financially we can maybe squeeze in a third spot this year and the next year.
Yeah, I understand that those are not like government funded roles. These are funded by the hospital, mostly the university.
Yeah.
And the academic side. So perfect. I don't think there are any more questions. So I'm just gonna actually, take you back to that hallway at the general, at midday, you're looking at the window and trying to figure out life. And then we pulled you into something completely you were not thinking of, So I'm not going to ask you to reflect on what have you achieved so far, because I think everyone today listening to you have reflected. Achievement has been fantastic. There's no doubt you've saved so many lives in the hospital, as well as jobs for many of us, who are going to be looking for jobs if this was not successful. So thank you. But what going in the future, where do you see this going? You innovate within the Juravinski and you've done fantastic and you're going to keep doing well. But then what is the future of hospital medicine? Back to Anne's question, what is the future of GIM along with hospital medicine, being hospitalist, solution to the healthcare in, 2 minutes or less? Yeah. Where do you see the future? What's the future vision?
I mean, I'd say that the future vision is definitely one of solidifying what we've done at the Juravinski and also expanding more so that we're able to provide hospitalist supports to other, hopefully, health systems in the region. We definitely want, I definitely want to, at the Juravinski, hoping to try to create a hospitalist teaching unit, so we can do a little bit more robust teaching. It can support our hospitalist fellowship program as it hopes to scale. And then, really creating a large pool of individuals who are keen on doing inpatient work, doing it well, and they can help the various hospitals in the region, and also really focusing on innovation and care delivery. I think that's the gap that and day-to-day function of the hospital. I think that's one of the gaps that as GIM we focus more on the traditional roles of academia. And so getting into some of the nitty-gritty of how the hospital functions, how inpatient work is done, and improving those processes, I think that's really a niche that I'm hoping we can move into, and that can help inform a lot of the work that our broader GIM colleagues do.
That's amazing. And I also hope that, as you state this, train hospitalists in an academic setting to be future academic hospitalists who can solve a lot of our issues in our healthcare system today by working very closely with the hospital. Haroon, Anas, thank you so much. Congratulations. This has been fantastic, great, taking us through this great journey and telling us about how you've done it in a pretty scientific way. And all of us wonder, how did he pull this out? So you've done it. Also, how did he pull this off? Sorry. And you've done it. And we know you did it fantastic. So thank you very much. And congratulations on your success. And thank you for sharing with us today. And I hope everyone have a good rest of their day.
Thanks, everyone. It's a team effort, lots of great mentors, lots of great leaders. Thanks.
Thank you.